Hi all. In this video we're going to see about some important physiological basis questions that can be asked from vision. So let's quickly see each one by one. First, why is corneal transplant usually successful? Or in other words, why isn't there any issues of rejection when we transplant cornea? Well, that is because cornea is an avascular structure and thus the antibodies cannot reach the grafted tissue to cause a rejection. And that is why it is one of the most successful transplant operations. Next, what is the physiological reason for blind spot? What do you mean by blind spot? Blind spot is an area which is located in the optic disc where the optic nerve fibers exit the eye. So see, suppose this is the fundus. We've got the macula, which is the most prominent or area of maximum vision, the center of which is the fovea centralis. Now, to lateral to that, we've got the optic disc. Now, it is through this area that the optic nerve exit the eye. Okay, so in this area there are no rods and cones because the optic nerve is going to exit through this area. So that is why it is called the blind spot, because there is no vision is possible at this blind spot. So there are no photoreceptors, hence no image detection, and thus causes a natural blind spot. So that is the physiological reason for blind spot. Now, what's the physiological reason for macular sparing? What is macular sparing? Macular sparing means, suppose we've got an occipital lobe lesion. In that case, even though there will be a visual field defect, your main vision will not be affected because the macula is spared. Remember, macula is the area of maximum vision. So you might have some visual field defects, but the main vision would be unaffected. Why is it so? Now this is because, first of all, macula has got a disproportionately large representation in the visual cortex. So just because there is some area, a lesion of some area will not cause a lesion to affect the macula. Secondly, it has got dual blood supply both from the middle and posterior cerebral arteries. So naturally, the effect of damage will occur only if both these blood supply is affected. So that is why we have macular sparing. Now the next question is, what is the physiological basis, or why is there maximum acuity at the fovea centralis? Now that is, what is fovea centralis? Remember, when we drew the diagram of the optic disc, we said we've got a macula, the center of which is called the fovea centralis. Now fovea is an area which is densely packed with cones. That means no rods are present. It is fully, we have got cones there, and not only that, each cone is connected to a single optic nerve fiber. Usually in all other areas we've got multiple photoreceptors converging onto a single optic nerve fiber. Here we don't have that convergence, so we've got a maximum resolution. Not only that, at this area the inner retinal layers are displaced laterally and the light falls directly on the cones. So which means there is maximum amount of light, that is without any leakage of light, it falls directly onto the cones. And only fine blood vessels are present. That means the center of the fovea is avascular. So again, we don't have any obstruction for the entry of light. And finally, it has got a disproportionately large area of representation in the visual cortex, which helps in enhanced processing of the image. That is why we've got maximum acuity in the fovea centralis. Next, why does near point recede in old age? Or why do we have presbyopia in old age? See, normally what happens, suppose we have a near object, the light rays that are coming from that near object will be focused onto retina by multiple mechanisms, one of which is the thickness of the lens would increase, right? There will be increased convergence of the lens so that the light rays will be focused onto the retina. But what happens with age? With age, the lens becomes less elastic, the ciliary muscle power will decline, so the ability of the eyes to accommodate, that means ability for the lens to accommodate for near vision, will decrease, and this will cause presbyopia, that is the near point will recede. The older individuals will have to hold it at a longer distance for clearer vision. This is the reason for presbyopia. Decreased lens elasticity, decreased ciliary muscle power, thereby reducing accommodation. So the next is, why is there hypermetropia in infants? So most infants or most newborns are physiologically hypermetropic. Well, that is because their eyeballs are shorter anteroposteriorly. So what happens? See, suppose this is the eyeball. The light rays coming from an object, they, because the eyeballs are shorter anteroposteriorly, what happens is the image will be formed behind the retina. That's what we call hypermetropia. That is why we say infants are hypermetropic. But this will be corrected because as the baby grows, the eyeball will elongate and the accommodation all will be proper. But at the infant age, because the anteroposterior diameter is less, the image will be formed behind the retina, which we call hypermetropia. Next one is, why is cataract more seen in conditions of diabetes mellitus? What do you mean by cataract? Cataract is a condition in which there is an opacity of the lens due to accumulation of water. Now in diabetes, from where does this water come from? See, in diabetes, what's the problem? There is hyperglycemia. A lot of sugar is there, right? So there will be more glucose in the lens, and this glucose will be converted to sorbitol via aldose reductase. There's an enzyme which will convert glucose to sorbitol. So what? If the sorbitol accumulate, it will increase your osmotic pressure, leading into swelling of lens and protein aggregation, and this will cause opacity or cataract. And not only that, when there is a chronic oxidative stress, it can also lead to denaturation of the lens proteins. That is why in diabetes mellitus, cataract will develop soon. Two reasons: one, due to accumulation of sorbitol, which cause lens swelling and protein aggregation, and protein denaturation. Next, why is the color perception poor towards evening? So to explain this, we have to know two things. Photopic vision is by cones, scotopic vision is by rods. So color vision is the function of cones. That is why I said photopic vision is the function of cones. Now towards the evening, what will happen? This light, the amount of light is less. So in dim light, what is going to be activated? It is the rods. Now you know rods, they are not cones, no? So naturally they can help in vision but not in color discrimination. That is why the color perception will decrease as the cones are less stimulated in the dim light. That is why we have poor color perception towards the evening. Next question, why does vitamin A deficiency cause night blindness? See, we know that vitamin A is required for formation of the pigments present in the rods. So if there is decreased vitamin A, there will be decrease in this is of Levin's retinal, which means there is decreased rhodopsin in the rod cells, which is a visual pigment. So the rod cells will not function properly. So naturally there will be impaired scotopic or dim vision. So during the night, the person will have difficulty in vision. So that is the role of vitamin A. Finally, why does pilots wear red goggles? See, what is the importance of pilots here? See, pilots are people who will have to move from areas of bright light or dim light very quickly. Now, normally when an individual moves from an area of bright light to an area of dim light, what will happen to his vision? He will take some time to see clearly in that dim light. No, that is called visual adaptation. Now, can pilots have time for that visual adaptation? No, right? So that is why they wear red goggles. But how does red goggles help in decreasing the amount of time for visual adaptation? See, red goggles, they block short wavelengths. That means it will block the other wavelengths like blue and green. So the rods, they are sensitive to low light. They are not stimulated by the red light. See, only red light is going to come through the red goggles, and this red light will not stimulate the rods. So rods are all ready and they are ready for vision. Okay. But what about cones? For cones, when red light comes, it is the L cones or the long wavelength cones that will be activated. So suppose it is daytime, the L cones will do its function and it will help the pilot to see. But suppose suddenly they enter a dim lit zone. that time the rods are already ready because the red light will not stimulate the rods. So the rods will quickly help in that dim light vision. So there will be this ensures that there is the pilots are able to read the instruments without compromising on night vision. It helps in immediate night vision readiness and smooth transition from light to dark condition. That means it helps to decrease the amount of time for visual adaptation for aviation safety. Okay, so that is why pilots wear red goggles is a very favorite question for the examiners. Next, what do you mean by consensual light reflex? What is light reflex? See, when light is shown on onto an eye, there will be constriction of the pupil of that eye. Not only of that eye, but the other eye also, to which the light was not shown. See, if this pupil constricts, it is called direct light reflex. If the other pupil constricts, it's called consensual light reflex. So now they are asking what is the physiological basis for this consensual light reflex. Now that can be explained with the help of this diagram. Here, when the light is shown into one eye, both pupils constrict. Now this is because, see, we've got the cranial nerve 2, that is the optic nerve that is coming here, and the magic occurs at this part. That means after it reaches the Edinger-Westphal nucleus, you can see that the information is sent bilaterally, that means to both the eyes, and it is this information via cranial nerve 3 causes constriction of the pupil. Okay, so cranial nerve 2 from the retina to the pretectal nucleus signals sent bilaterally to Edinger-Westphal nuclei activates cranial nerve 3 to constrict the pupil. So this indicates that there is an intact optic as well as oculomotor nerves bilaterally, right? So that is the physiological basis of consensual light reflex. So if quickly seen some important physiological basis questions from vision. I hope this was useful for you. Thank you.